Of course, people who are already experienced in nuclear cardiology, I'm not going to be teaching you anything, I'm not going to be suggesting anything, but those who are just starting can probably take a couple of considerations from this lecture. And of course, it is also useful to review some aspects. This was taken from the American report, and it mentions a couple of important things. First of all, we are about to report and we have to review the clinical history of the patient or the request of the doctor so that we can clearly define the clinical question. This is fundamental. We truly have to know what the physician or the cardiologist expects, what question he or she expects us to answer. So it is not surprising that sometimes we find a patient that has underwent a recent diagnosis and their result could be overlapped with ours in terms of the prognostic value or the risk identification value. Or we also have to check the recent tests that the patient has underwent so that we don't duplicate them. If the clinical question is not clear, or if we believe that we are not representing, or maybe our test is not the most appropriate one to respond to that question, then we should discuss with the referring physician about this indication. Of course, we can't always do that. This would be the ideal situation. We are going to look at cases of patients afterwards because some patients would not be benefited from a study. So why don't we just do a different thing or so on? So actually we have to discuss the indication with the physician. We have to plan the technical protocol so that it's appropriate for that patient. We just had a patient for an exercise test with an amputated leg. So the doctor got to his office. He sat at the other side of the desk and he said, "Dr. Gonzalez, what did we say that we were going to indicate? A nuclear study, doctor." "Ah, okay. Well then, myocardial perfusion sensitized with exercise." And the patient, he was a diabetic, he was amputated. So we actually have to plan the technique appropriately so we don't run into surprises, and the response technique as well. What is a report? If we go into Wikipedia, the definition of a report is a document prepared in order to communicate information about a matter of interest to an organization, a person, or a system. It refers to results obtained or verified by the author of the report. So the author of the report should be aware of what he or she is signing or adding to the document. This means that if there's a contrast in the myocardial perfusion of Mr. Gonzalez, that there was a defect of reductible perfusion for the lateral wall, and then he said, okay, lateral wall ischemia. I didn't see it, another person told me, so okay. We need the necessary understanding of the case. We need to explain the methods used. It analyzes and interprets the data gathered. It establishes the conclusion, and eventually it proposes and recommends a solution for the issue or the future steps to be taken. You see how complicated this is, right? And this is something that in most cases we either ignore one or more steps of this paragraph, right? So remember that we are not authors, we are physicians, consulting physicians. So we have to gather the data, analyze them, interpret them, and we have to recommend the next steps to be followed for the solution of the problem. Remember that the report is the final result of a very complicated process that is very expensive with the involvement of an entire team of people, which could be similar to an assembly line of a vehicle. It is the most important component taken individually. If we see all the different components of the process of nuclear cardiology, individually, we do consider that the final report is the most important thing. This dates back to 2011. Walker's recommended in this editorial, and he said that the clinician normally does not have deep knowledge of the diagnosis due to images, and he or she trusts that the specialist provides them with the pertinent information. Therefore, the responsibility of the nuclear cardiology is to inform the findings to the physician through a report that is accurate, understandable, and clinically relevant, so that they can make the proper decisions in relation to the handling of the patient. This is very clear and precise in relation to what the author wants to communicate. And this part, the understandable and clinically relevant report, this is what we have to consider the most. So the idea is to send a message, right? To convey a message. The message has to be in an orderly manner. It has to be structured. It has to be focused, clear, consistent, and relatively brief. It has to have common sense, and preferably it should have feedback as well. And feedback is practically to see what is the opinion of the physician in relation to the reports that we prepared. Was it relevant? Was it useful? Was it not? And so on. So this is the structure of the report. This is common sense. You already know this. These are scientific data of the patient, clinical history data of the problem to be solved, the methodology used, the results obtained, the interpretation, and conclusions. There are several publications that talk about the standardization of a report of nuclear cardiology. And here we have all the steps to be taken. This is included in the literature. Here we also have publications of atomic energy, which were prepared with this purpose in mind. And the identification data of the patient, of course, we already know about this, but this part is very important, to be able to locate the patient, or a way to be able to contact the patient afterwards, because of many reasons. One, for example, we gave him or her the incorrect report. We have to say, Mr. Gonzalez, I'm really sorry, but there was a mistake. Or two, we want to tell him that the report means that he should go to the physician as soon as possible. We did not tell you when you left our office, but now that we have reviewed your study, we understand that you should go to your physician as soon as possible. 3, in monitoring and follow-up, we are working on this, and we want to do the follow-up. What happened with that patient? We want to know if he was revascularized or not, if he's living still or not, if he was hospitalized because of different cardiac risks, if he suffered an infarction or not. So the contact with the patient is quite vital. The clinical history and the problem to be solved, it's quite obvious, the importance of this. And the paradiagnosis for the risk stratification for myocardial viability, or maybe to see if the respondent is going through resynchronization therapy and different assessments, pre-op assessments, and so on. The methodology used is very important, because especially when the patient in his evolution, he's going to be subject to a second study. We have to know how the first one was conducted. We know that he did it in an independent laboratory, and then this information would be important for us or for a colleague that is going to see the patient in another lab in a year or 2 years' time. So we have to see what type of stress was conducted, if they followed the type of protocol, the type of equipment, if they took the images, and the type of radiopharmaceuticals, the dose, and finally, we see the need of including information about the effective dose so that the patient can have a dose history of him or herself. For example, yesterday we took a tomography, today we had a nuclear imaging, tomorrow he will have a thoracic image, and the day after that he'll have another process. So all of this has to be included in the report. In a specific institution, for example, they could be implementing the dosing history of the patient to see the effective doses of the patient and of the studies that compromise the radiation. The results obtained, we have to focus on different things. The technical quality of the study, if it's a diagnostic study, or if it's suboptimal or perfectly usable for the diagnosis. And we are interested about the information about the stress test so that we can include it in the clinical interpretation. We are interested in the morphological characteristics of the heart and other findings, not just of the perfusion, but we want to see if there's hypertrophy in the heart, if it's dilated, how much, and if there's TID, if we can see the right ventricle, if there's pulmonary uptake, and then the perfusion data, the ventricular perfusion data, of course, and we already talked about this. When we look at the crude studies, we have to have the daily quality control of the quality of the test to see if it's reliable from the technical perspective and to see if the information that we're evaluating or interpreting is correct. This type of things are very important. As we can see here, this automatic placement of the epicardial and endocardial edges in one of the nuclear cardiology programs that are commercially available, we see how there's a rest. There's an error here that goes beyond the edge of the valvular edge, and it establishes areas that are larger, and this is going to lead to errors in the quantification of the volumes and the ejection fractions and so on. So this is part of the quality control when we receive the study, and this can be corrected manually, right? So this can be corrected. And if we are given incoherent quantification data, it is very often that when we look at the areas, we can see errors of this kind that could be corrected. The stress test, of course, it's very important to see what happened. We have to learn about the results expressed in a similar way. If there are arrhythmias or if there's a permanent arrhythmia or not, it's important to see how reliable the triggered gate is, how was the behavior of the patient, if he suffered symptoms, meds, and the information of the EKG. This is what we mentioned today. This is the morphological part, the morphological information. And here we can see a transient dilation with uptake in the right ventricle. This information should not be ignored. Pulmonary uptake, perfusion. So it is very important not just to establish the existence of the perfusion effect, but also to categorize them and classify them. If they're fixed, reversible, partially reversible, mild, moderate, severe, it's important to add the adjective so that the treating physician or doctor, they need us to add the adjective, not just to say if the patient has ischemia or alteration in the myocardial flow, but we have to mention the severity as well. And the topography, right? And the score, how we can measure this more than just categorizing in a subjective way. We have to know how to transform this into numbers, because maybe these numbers are just useful internally for us as a second reading, or it could be that the referring doctor is also interested in this quantitative analysis. For example, here we can see that for the 17-segment model, the score from 0 to 14 will tell us if it's normal or if it's severely normal or if it's intermediate. And we have perfusion scores that you probably know of. Normal would be from 0 to 3, mild from 4 to 8, moderate from 8 to 12, and severe more than 13. And the total deficit of perfusion, which would be the myocardial percentage involved, which is the score, the perfusion score, which is one of these numbers, divided into the maximum possible count. And of course, there's a prognosis value for risk stratification. For example, if we take the triple X, which is normal, mild, moderate, and severe, we see that we have the annual rate of myocardial infarctions and cardiac death in this population, this is a classical article, and we see how this is proportional to the risk of events according to the extension of perfusion. This has been shown already, the importance of handling a patient, that we can establish a ischemic myocardial percentage. The other thing is the topography and the identification of the culpable vessel or the artery responsible. And fortunately, in the programs, we have this information properly. Of course, every patient would have their own coronary tree with certain variations, but this is similar to the dysfunction of any average patient. So we have the territory of the anterior descending wall and the right coronary. Is important that we also provide this information to the doctor. Ischemia in the territory of the descending anterior of moderate level, for example. So these are real cases, right? Descending anterior, what is affected? Right coronary, the inferior wall, and the lateral wall. This is for a more experienced eye. This is easy to conduct. And of course, we have the smaller effects that could correspond to branches of the main arteries. And the polar maps also are very useful for this. We have characteristic patterns of each of the arteries involved in ischemia. The ventricular function and the importance of having this information, we have to see what happens with the ventricular function between the stress response conducted. We can see that the ventricular function, the ejection function, is relevant because the breaking point is at approximately 40% to establish the increment of risk due to cardiac death below this line. It'll increase a lot. Remember that ventricular function is quite a good predictor of cardiac death, while it could also be applicable for myocardial infarction. Of course, it's not certain, but the trend in medicine is by implementing this type of studies. It's also important to see or look at the difference of the ventricular function post-stress, because this will mean a myocardial haze due to ischemia. And as we can see in this population, haze was after the ejection projection, which is the biggest predictor of events in this type of patients, above the defects of reversible perfusion and ICT with a cut of 1.5 millimeters. So this is important, especially if we have the phase analysis software so that we can see the synchrony, ventricular synchrony. And of course, if the question is about viability, we already conducted a viability study with nitrates, and we have to properly inform and answer appropriately to these questions. The interpretation and conclusion. Before we interpret the images, we have to consider the following aspects. The indications of appropriate studies, we have to see if it was appropriate or not. Do we have complete information? Do we have the clinical data? Did we conduct all stages of the study, or did we follow the protocol? And if the results obtained are reliable, the preparation of the patient, was it correct in terms of removing caffeine, the medication to be suspended, if the patient is using beta blockers or not? All this information is necessary. If the stress test was sufficient, if quality control of the equipment was conducted and accepted, and also if we followed the protocols established. So we are going into the field of the use criteria, appropriate use criteria, because this doesn't just have clinical value, but also legal, medical value, financial value, and ethical value. We could conduct a study, and we know that it's clearly not indicated because this can mean higher income for our clinic and our hospital. But if it's not acceptable, or maybe it could have a legal medical value if the patient can think of a thing during the stress test, and if the stress is not proper or it's unnecessary, or maybe we choose the test that is not appropriate for the patient. There are also many publications. This is one of them. These are appropriate use criteria from the different American associations. And going back to Del Valle's theorema, as I commented before, I said that we could use this if we actually establish the pretest priority of the patient. In the case of the diagnostic question, we can establish the pretest priority, and we can see if the indication is appropriate or not. Of course, as we have seen, if we have low pretest priority with a positive test, the probability continues to be low. If we have high probability, even if it's high probability in a negative test, their priority or probability continues to be high, and therefore we are not adding anything with our results. The results obtained, all of this, all these questions, if we have it in electronic or physical form, if we have a traceability form where the patient, from the moment he comes in until he leaves, it'll make our work easier, because when we have to prepare the report of the patient, we already have condensed information here. This is a form that we actually use in our services. So here we include all the information from the moment the patient comes in all the way to the stage of the report. And it's also coded by color, and we have the person responsible for filling out a specific section. For example, in these two first sections, it is the receptionist or the administrative person or the secretary, the person who has to fill in this information. This other section belongs to the technologist or the radiopharmaceutical person. This other section belongs to the nurse or the nurse that is injecting the patient. And this is a section that belongs to the cardiologist that conducts the stress test. They have to include minimum data. The acquisition, the technologist. The processing, in our case, it would also belong to the technologist. And the report would belong to the nuclear doctor or the cardiologist. So this is a way of incorporating everything that we need about the patient in a condensed way. And of course, the conclusion should match the clinical question. We know that the question would answer if the patient has coronary disease or not, if he has a post-infarction residual ischemia, and so on. So we have to try to explain any. For example, if we try to have an explanation test, we have to explain inconsistencies. So if the stress test was 2 millimeters or 3 millimeters, but the perfusion was normal. But if we have a patient, we do have to say that even though there's normal perfusion, this person should not be considered to be of low risk because he has a high-risk stress test. So many doctors tend to think that if the results were normal, it doesn't matter what happened before, the patient will be at risk. And we know that this is not the case. The risk is depending on the results of the stress test, among other things. And we also have to recommend steps to be taken, maybe tomographies. And we have to remember that we are not cameramen or we are not narrators of an event. We are consultants. People expect a result from us and not just an opinion. For example, if we say partially reversible defect of the lateral wall, well, we have to interpret this, right? This is the descriptive section, not the interpretation section. And when we talk about risk, we have to try to remember what we are talking about. Under risk, or this is a rate of events of less than 1% per year, moderate risk, an event rate of up to 3% per year, and high risk, this would be an event rate of greater than 3% per year. You would say high risk, in reality it doesn't seem to be that high because it could be 4% and it's already high. But it is significant. It is significant for us to have a probability higher than 3%. So there is a discussion if we have to talk about risk, if we shouldn't talk about risk in our report. Okay? A doctor was saying the other day that the patient sometimes reads the report and he or she can interpret it in an alarming way. This could happen. He could be very concerned because of this, and maybe he won't see the cardiologist in 2 weeks' time. He will feel anguish. So we have to see how to handle information about risk. And this depends on the environment that we are in to see how we can transfer this information. But what is important is that we learn how to identify high-risk studies for those who are just starting in this specialization. Just like in this case, it's clearly of high risk. And that patients, high patient risks in high-risk patients have to make sure that this information gets to the patient in a way. It doesn't matter how or when, but the doctor should be aware that his patient has a high-risk study and he will know what to do with it, right? No, actually, it is common for us to find these patients, and what we do, since it's an institutional service, it's not an isolated clinic, what we do is that we refer this person to emergencies with our report, and we say, okay, look, I'm going to send this patient to you. He just conducted a test with us, and he has high-risk results. So normally this patient will be hospitalized, and in 24 hours' time, he will have his catheterization. This is a normal process.
But it's important for the treating physician to be present. And well, of course, this is coordinated with the other one. Being late is like taking out all the oil of a car. Everything that was done is lost. Because everything was done, but the patient receives his report 2 weeks later. And meanwhile, there's an infarction, or are on holiday. Where is a high-risk study? Where are they? In the Philippines? Oh my God. The patient needs to plan their life, of course, according to the results. And if you cannot be on time, be early. This is all. Remember that it's a process. Let's not just think about perfusion. We have another host of parameters that have a high clinical importance, and all this information, the report is a bottle of juice. It's ready to be consumed, but the rest is all the fruit in the market. So we need to find out what are the ingredients. We need to condense them and make them be ready to consume them. And we need to find out a way to know if we're doing things right, find out what the referring physician is thinking about our work. Thank you.